Good evening, everyone, and welcome to our first webinar for the new year, Common Shoulder Conditions. My name is Helene. I'm the Workforce Development Officer at Westvic PHN, and I'll be your facilitator for this evening. Alongside me is Jade, who is also on our Workforce Development team. I'd like to begin by acknowledging the traditional owners and custodians of our unceded lands and waterways. We recognise their diversity, resilience, and the ongoing place that First Peoples hold in our community. We pay our respects to elders, both past and present, and commit to working together in the spirit of mutual understanding, respect, and reconciliation. We support self-determination for the First Nations people and organisations. Just a little bit of housekeeping. You can view the majority of our webinar recordings freely on our PHN Learn YouTube channel, and the link to that access, we will put the link on the screen. You should see that now. Please see our upcoming events on the screen, and you can register for these events via our website, and the link is also there in the chat. Please make note of the Westvic PHN health pathways relating to this topic, and they're on the screen at the moment. You should be familiar with those pathways, but if you're not, it's a free online resource with localised clinical and referral information. And you'll see the slide here with some of the related pathways. Westvic PHN will provide a certificate of attendance, so please take a moment to check that your full name is displayed accurately on your screen. If not, or if you're unsure, just rename yourself or type your first and last name in the chat box. This will ensure we can issue you with your certificate. This event is being recorded, so please keep yourself on mute unless you would like to ask a question during the designated question and answer time at the end of the formal presentation. We do encourage interactivity and discussion, so feel free to type questions in the chat box at any time, and I will ask them on your behalf to the presenters at the end. It'll all be anonymous in the chat. Oh, well, people say, yeah, it'll be anonymous. Your feedback is important to us, so please take the time to complete the event survey after the webinar. There's a link in the chat box to complete this. So the presenters for this evening are Associate Professor Kevin Eng. They're all orthopaedic surgeons, Professor Richard Page and Dr. Michael Bullen. I will now hand over to Kevin to commence the presentation. Thanks, Kevin.
Thanks, Helene. Hi, everyone. Happy New Year. I will see if I can do this sharing thing. How's that looking? Are we okay there, Helene?
Looks okay there.
Yeah, that's good.
Okay. Thanks, everyone. I'd like to take the time to actually introduce Professor Page, who is rushing home from work and sends his apologies. He will Zoom in as soon as he's able, but he's being very professorial at work. I'd like to introduce Dr. Michael Bullen, who's just joined Barwon Health at the middle of last year and is an upper limb fellow in a very similar vein to Professor Page and myself. We're very excited to have him on board. He's a Queenslander originally, but he's still a nice fellow. He's trained in Victoria and has a PhD from Melbourne University, as well as doing a fellowship in Canada in shoulder, elbow, and hand surgery. So he's been brilliant to have around, and he has been a wonderful fellow to bounce ideas off without complicated cases. So tonight we thought we'd go through some common presentations. I had a chat to some of my GP friends, and we put together some things that would commonly present. The patient with a dislocation, the patient with a painful arc or bursitis or subacromial pain syndrome is what we call it now. Patient with a rotator cuff tear. Proximal humerus fractures are pretty common in our society. And what to do with an osteoarthritic shoulder. And just in summary, an X-ray and an ultrasound is a really good baseline exam. You're most welcome to call any of the surgeons at Geelong Orthopaedics anytime. We basically all work together, and we're happy to support you. And if you've got any questions, please type them in the chat at any stage. So if we move on to the first case, which is the dislocation, um, we've got a 21-year-old typical football injury. Pre-season started about a month ago. It's been reduced in ED. It's the first time it's come out. He's a uni student down at Deakin and wants to play on, and you catch up with that patient in your rooms about 2 weeks later. The reduction X-ray is reported as normal with no fracture. And so he's been sent back to you for further care. And I guess there was a raft of questions about what to do with the first time dislocator. And the first one is, well, if the X-ray is normal, what else should you be doing? And Michael, have you got any thoughts about what further imaging you might
Yeah,
order?
I think as a background, I think we're changing how we manage these a bit. And where in the past, if a patient felt that they were stable after reduction and the X-rays looked okay, let them sort of continue on and see what happened. And if they turned into a recurrent dislocator and sorted out down the track, I think we've now recognised that that approach leads to more problems down the track. So we tend to be a bit more aggressive with early intervention, particularly for this type of patient, high risk young male contact sport. His risk of redislocation is very high. So I think after the sort of other usual steps, the next imaging I'll go for would be an MRI.
Yeah. And I guess if would you request an MRI, say, before they hit your outpatients, or would you just order it from there? Or
I'm mindful of logistics a little with that. I guess it would obviously streamline things to have an MRI to be able to make a decision and book an operation the first time you see them. That's sometimes not always possible. So yeah, I think end up ordering a few from clinic, but at the same time, it's great when they turn up with an MRI already.
yeah. And role of ultrasound or CT, would you ever sort of think about that?
CT I use whenever there's a suggestion of bone loss, either on the glenoid or humeral side, and a Bill Sachs or bony Banker type lesion. Ultrasound I wouldn't typically arrange. I appreciate it's easy to get as a first step, maybe to exclude a cuff tear in an older patient, but MRI is the best test, and CT if there's a suggestion of bone loss.
Yeah, okay. I mean, I pretty much do the same. And from a practical point of view, if I get a referral from a GP, I'll just order the imaging there and then, trying to get that done before they catch up with me. And at what point, they've sort of, it's happened 2 weeks ago, and sort of ED have just shuffled them out the door because they're absolutely overwhelmed. What At what point do you engage physiotherapy or exercise, or how long do you want them in a sling? Do you have any sort of feel for that?
Yeah, the difficulty, I guess, is particularly for someone who's keen to get back to sport, wanting to solve their problem sooner rather than later. The role of physio might be a consideration for, say, a high-level athlete who relies on the sport for their income nearing the end of the season and they want to play out the last game or two. But I think in the typical punter we get, there's not a huge role except for limiting adhesive capsulitis.
Yeah, right. Um, if you're um, contemplating surgery, do you have a sort of I might go to the next slide. Do you have a sort of algorithm or something you just a rough outline you can give to people so that when the patient asks what sort of surgery might I
So
be facing?
I tend to base mine on the glenoid side first. So if there's a significant amount of glenoid bone loss, I would go straight for a bony based procedure like a ladder J. The numbers for that are a bit of a moving target, and I probably am now accepting a higher amount, high percentage of glenoid bone loss, maybe up to 20%, for a soft tissue procedure, like a Bankart repair with the addition of a remplissage. And then for the no bone loss or minimal bone loss ones, essentially just doing isolated Bankart repair.
Okay. I think Professor Page is here. Prof, can you confirm that you can hear us okay?
Yeah, thanks, Kevin. Thanks, Michael.
All right, he's welcome.
Apologies for being a smidge late.
No, we were early. Do you have any thoughts about remplissage, Richard? Remplissage is this picture in the middle here, where not only do you address the glenoid, but you sew some of the infraspinatus muscle and tendon into the bone defect at the back of the humerus. Is that something you have in your practice much, Richard? Or
Yeah, selectively. As Michael suggested, I would use it when there's perhaps been an early bony Bankart. In other words, there's been a little early rim fracture off the front, but not significant bone loss in a contact athlete with a large heel sacs. So I wouldn't do it if there's no dent at the back of the head, the heel sacs lesion. But if there's a sizable one, particularly if it's borderline where it might, what we call engage, so as they externally rotate, it might catch on the front, then that's a good indication that the results for that have actually been quite good. And you look internationally, they're showing some equivalency for intermediate bone loss. I'm not a fan personally of a lattier, in other words, doing that right-hand type procedure if there's normal anatomy. I know in some parts of the world they're enthusiastic about that, but we do know that the risks of that are a bit higher if you look at all causes for reoperation and representation. So like Michael, I will. My default is if I can do an arthroscopic keyhole type reconstruction, which is generally a repair at the front, plus or minus if assessing them if they need some additional surgery at the back, which is the remplissage, then that's my go-to.
what if they're in season, Richard? Does that change?
Sorry, what's that?
What if they're, say, in season and they want to make it to the, everyone's going to win the grand final for some reason. I'm sure only one team can win, but that doesn't seem to be true. Does that change how you address things?
Yeah, that's a good question. And I think, we're talking about specific groups and then you've got to break it down. Are we talking about just the local club footballer whose, livelihood is actually outside football, in other words, work? And then you've got to have the conversation with them. Well, if they keep coming out, is that going to pose a problem from Monday to Friday working versus Saturday? It's a bit different for the professional athlete whose whole livelihood depends on what happens on the Saturday. In other words, being able to play. But if they've in that peri-final season, you counsel them, you let them give them the information that they make a decision. But if they come out once more, I think it's game over. Then they need to get on because, as Michael suggests, we do know that from some randomised controlled trials that the risk benefit is in favour of doing early intervention, early surgery. It significantly reduces the lifelong risk of redislocation. And dislocation is not neutral. We know that people who have more than one dislocation, so 2 or more, have a 20-fold increased risk of getting shoulder arthritis, 20 years later. Well, if you're talking about a 20-year-old, that's in people who are still in the middle of their working age, 40s to 50s.
Yeah.
What about you, Kevin? Can I ask you, how does that sit within your approach?
Yeah, very similar. I have a long discussion and, even we've had discussions among sports team doctors and myself. And I say, ultimately, here's the risk. You can accept that or not. And I've had players, come through and I've had some fail. I guess the other thing is, look, Doc, when can I get back to my football? So if you're going to do this, say, whatever a standard keyhole procedure is, do you keep them out for a certain length of time? What do you tell them, Michael? Because that's a common question.
Yeah, a bit of a risk benefit again on on that one, the professional athlete is probably tolerate a higher risk of going back sooner versus a club level player. The sort of standard club type player, 3 months would be about a minimum time frame for me. Ideally, if I could get them to 6 months, that would be my preference. But often, if you say that you're happy to shorten it to 3 months, they'll be back out there 3 months in 1 day. So,
yeah, that's very true. And it's a very motivated group.
And it might be worth noting, I think even at the AFL professional level now, they're fairly, having gone through the ACL vogue of trying to get them down to 4 months, where there was about a 400% increase in re-tear rates. There's an understanding now that most of these, if they can, they'll manage to the end of the season because they want to have 4 months before they get back to even contact training, and it's generally 6 months before play, 5 months if they do a functional assessment. At least there's a little bit of work trying to correlate, functional testing with return to play. So maybe 5 months. So there is an appreciation that they're unlikely to be safe at 3 months.
Yeah.
And you can measure differences in their reaction times, et cetera, which puts them at risk.
Yeah, very much. And I think ironically, the younger they are, the longer I try and keep them out.
Exactly, because the risks are higher, the recurrence rates are higher.
Yeah.
That's probably for the audience, for those in primary care. It's one of these things is that we know, and it's well documented in a lot of historic population-based studies, that one of the number one risks for recurrence in a traumatic setting is actually younger age. So younger patients are at a higher risk of recurrent instability from a traumatic dislocation, and that sort of infers that there's something about the maturity of whether it's the capsular ligamentous anatomy. We're actually planning a little study on that. Particularly in the adolescent, versus whether it's neuromuscular development. The shoulder's an inherently unstable joint, so it needs all those things to be going right. And in the younger patients, there's something that's not right, and that scope is not mature yet, as opposed to, say, a 25 to 30 plus year old who has a first time dislocation.
Yeah, anecdotally, we're seeing more and more of those
adolescents.
And it'll be a fascinating study we hope to get done this year. Well, speaking of the opposite of adolescence, we've just had the Cadell Evans ride, and there was a people's ride on Friday. And if you're a bit of a mammal, so to speak, and you drop your wallet and try and pick it up, you might dislocate your shoulder falling off your bicycle. And this is sort of the other end of the spectrum where, they get reduced in ED and sent off to the physio, but 3 months later they come back to primary care and they're really struggling to sort of lift their arm up still, despite working really hard with the physio therapist and rehab teams. Michael, have you got any thoughts about any investigations you'd want in this different age group?
Yes, the main thing for me is probably clinical in this presentation, trying to differentiate whether this is a massive cuff tear, whether it's acute or acute on chronic, versus a neurological issue or even cervical spine, I guess. So clinically would be the way I tend to differentiate that. And then if I was suspicious about a cuff tear, depending on what imaging they had, assuming previous x-rays and things, I'd go for an MRI.
Sorry, you get an MRI?
MRI.
Yeah. I think I'd have a pretty low threshold to get one here as well. So it's sort of an MRI for all groups, but you're looking for something different. I guess the other possibility is adhesive capsulitis in this sort of 40 to 50-year-old group, or maybe a touch older, they get a post-traumatic frozen shoulder. Richard, do you treat the frozen shoulder, or do you think the post-traumatic frozen shoulder has a different course compared to the idiopathic? Or
yeah, I tend to wait it out, a bit less aggressive, if you like. You certainly wouldn't go injecting, or sending them off for cortisone or hydrodilatation, because what you don't want to do is disrupt the healing process. from assuming that they don't have, as Michael rightly pointed out, that rotator cuff co-injury, which is more at risk in this age group. But if they don't have that, you really, the recurrence, as I've said, it's the inverse age correlation to recurrence. So the recurrence risk in this group is a lot lower unless they've got a cuff tear. Then it tends to go up, or a fracture. Remember, this group's also at high risk of getting a GT fracture or something like that. But to answer your question, no, I tend to hold out. But if they're really going backwards at between the 3 and 4 month mark, then we might change course and act. But they're going to be stiff, so you accept because of the trauma, they're going to be stiff for a bit longer. But that is, and a part of it is counselling the patients early so they know what to expect, and then they're generally able to ride it out.
Yeah, and it's sort of 3 months down the track. At what, from a practical primary care point of view, at what point would be ideal to refer this kind of middle-aged patient to say a specialist like yourself, Michael? Would you want to see them earlier if they, just in case they had a big cuff tear, or later if it's because it's not so urgent, or what do you think?
Definitely earlier is better if there's coexisting pathology. A acute cuff tear would be something we'd get on and try and repair before we had any muscle atrophy, and that's better sooner. But adhesive capsulitis obviously not as urgent.
Yeah. Fair enough. Okay.
Maybe just a quick note on imaging, Kevin, because it's come up a few times about MRI. There's a couple of things there. Clearly, MRI availability is much wider now. It used to be, back in certainly my living memory, only one MRI scanner in the town, and now there's about one on every street corner. So availability is higher, cost is lower, and also, in fact, the quality of the scans. There's a lot more 3 Tesla scans. So historically, we used to have to get MRI arthrograms. So it was a bit of a deal to get an MRI even on a younger patient. You had to because it was invasive. We don't now, and the quality of a 3 Tesla scan on labral pathology is really high. So I think it is useful even in the primary disclosure, particularly the thinking about surgery, because you do pick up other co-pathology like biceps root tears and a whole lot of things that change your conversation with the patient a bit about what may be involved in the surgery. So, I think it's in this traumatic setting where the incidence of co-pathology is over 15%. It's not insignificant. That's just my 2 cents worth. That I think MRIs are reasonable, but they do overcall things like rotator cuff pathology in trauma setting, and that can create a few other issues occasionally. So occasionally, you will go back and get a more base level, or I will an investigation if I'm not sure about something. Just look at global structure without all that confounding edema.
Yes. Yeah. And I was saying before, I'm certainly happy just to receive the referral and just organise what I think needs to be done just to simplify life for people where we can. But yes, sometimes I wonder if the M in MRI stands for milk bar, because they're sort of turning into that sort of frequency. Another middle-aged sort of common problem is where you've got a 55-year-old patient. They've had 4 months of a painful arc, had lots of physiotherapy. You've ordered an X-ray and an ultrasound, which is entirely reasonable. There's no calcific tendonitis. There's no arthritis in the glenohumeral joint. No rotator cuff tear. But look, an ultrasound, it's very frequent to see bursitis on an ultrasound, and I'm not sure if this is also the case in your Canadian experience, Michael. But what was your experience with this patient? Intact cuff, but painful arc.
It was it's received a lot of airtime the last few years. This presentation, some good research done in Australia about probably changing the way we treat these or should treat these. I think anecdotally they can do extremely well jumping in and doing a bursectomy or arthroscopic procedure, but turns out they probably do just as well not doing that and potentially sending down the physiotherapy or non-operative management type pathway. The Canadians had horrible access to MRI, so very infrequently saw an MRI, but the ultrasounds we frequently for the presence of bursitis.
Yeah. Richard, what's sort of your current practice with the ultrasound diagnosis of bursitis in a patient with a painful arc?
Yeah, if I given that we often see them and they've had some baseline treatment quite appropriate before, I'll always get an X-ray. I not because some of these patients do can mimic painful arc, but in fact it's early osteoarthritis. Now, presuming that the range of motion is still intact, in other words, they haven't got a frozen shoulder or they're not brewing a frozen shoulder, then I would follow the non-surgical line. But I do I do use targeted corticosteroid injections in this setting, and I think the calcific tendonitis is a good thing to look out for, but there's a lot of incidental calcific tendonitis, but sometimes you can see it, and there's a lot of it. This is where MRI is useful. There's a lot of edema, and it actually looks like, in inverted commas, a boil within the rotator cuff. I will intervene with those, either offer them if it's really acute, barbotage under ultrasound, or do the same arthroscopically. But for the pure painful arc or the painful arc syndrome, as you rightly referred to earlier, we know that there is, whilst they get improvement with surgery, there is equivalency over time, and certainly at 6 and 12 months with both physio, usually with adjuvant targeted bursal steroid injections, if they've got a true bursitis, in other words, if they've got an inflammatory looking bursa.
Yeah. Yeah, and I just put this MRI up because that is a genuine, at least MRI diagnosis of bursitis. You can see that big sort of rim or crescent of fluid right through the bursa, whereas you frequently get an ultrasound that says bursitis, please, maybe we could do this to them, and then you get an MRI that doesn't show anything, and I'm never quite sure what to make of that. But I think, as you say, X-ray and MRI and ultrasound are all useful, and I just, for those out there who may not have seen this in the Lancet, there was a study that looked at subacromial decompression, and there was a sham group, a decompression group, and a physio group, and they all pretty much ended up with a very similar patient-rated outcome at 12 months. So the number of subacromial decompressions we have done since 2017 has really dropped markedly, and we concentrate on physiotherapy, injections, analgesia, and non-operative modalities nowadays. But that's been a significant change in that group.
Yeah. Perhaps one additive to that is that if you, I know you and I have interrogated and teased apart this study at great length. There was variability in the entry point for some of the patients, and I'm just saying that because the group, the GP colleagues may occasionally see us doing something like this, but it's usually a different patient to this study. If they've had 12 or 18 months of non-operative treatment, they've got maybe other co-pathology like an AC joint arthritis, and we might do a decompression as part of the treatment of that. And that's a segue into there's physio and there's physio. So one of the problems is the entry point. Patients have said they've had physio and they've gone to a physio once and they had some TENS or something like that, and or an ultrasound treatment, and they didn't do any ongoing exercise program. That's not physio. That's actually just akin to no treatment. So they need to have done and adhered to a structured rotator cuff strengthening program. And there's there's a number of these published, but they're quite well standardized, and you need to sort of interrogate at all levels, including in general practice, actually what are they, it's not, I saw a physio twice, actually what are you doing daily? What's your daily exercise program? And that needs to happen for a minimum of 3 months.
I encourage them to do it bilaterally as well.
Yeah, good point. I totally agree. Yeah.
Very practical. But yes, and it's called subacromial pain syndrome because sometimes we don't really have a great diagnosis, but if you can make a diagnosis, you can certainly zero in the treatment, as Richard was saying. Well, similar vein to that, but actually now has not just subacromial pain syndrome, but a definite full thickness supraspinatus tear. So again, truck driver, 63, 6 months of pain. Osteopathy is a frequent treatment that I see as well as physiotherapy. Painful arc, but relatively preserved range of motion, but can't really get overhead very well. No arthritis on the X-ray. A full thickness tear on the ultrasound. Michael, what would you be looking to do next?
Yeah, essentially this type of presentation, I'm trying to stratify whether this is a subacute tear, which potentially is, and along with the presence of pain, how much they have compensated for that rotator cuff tear. So it's possible that this patient may go on to compensate fully for their cuff tear with a period of physiotherapy and have a decrease in pain, but at the same time, they may have ongoing pain, which may warrant doing something after if they fail a course of non-operative management.
Yeah. Would you base decisions purely on the ultrasound, or would you seek something further?
No, I tend to an MRI again for this presentation.
Lucky we got lots of them in town. Yeah. And I guess there's various types of truck drivers. If this guy was having to load and unload the truck as well, as opposed to just doing deliveries around town, would that change how you thought about surgery versus?
Yes, I think that if he can't perform his daily truck driving duties, he falls into that uncompensated category, which pushed me sooner to do something with him.
Yeah. What about you, Richard? I know you're currently doing the Australian rotator cuff trial, which is sort of exactly this patient. But
yeah,
what are your thoughts?
Well, certainly, maybe just a quick note on the study. We're doing that because one of the perhaps dilemmas for us to understand the results and the outcomes in the literature of this is that we know that we treat globally and nationally a lot of rotator cuff tears, and patients, there's good evidence patients do well from surgery, but the dilemma is that they do well irrespective of whether the rotator cuff heals or not. So the question is, does having an intact rotator cuff, is that necessary for a good outcome? And anyway, we're doing a double-blinded RCT looking at that very question in surgery. But again, it's a matter of balancing out who the patient is, what they do, what their symptoms are, and what non-operative treatment they've had. If they just turned up and there was an atraumatic tear identified in an ultrasound, they've had no injury and they've had insidious onset pain over 3 months and had no treatment, I think exactly as Michael said, I'd say, okay, well, let's just see how you respond to a course of physio first. But if they've had all that and they have failed that, then outside the study, I'd offer surgical repair, assuming on MRI also that they don't have a really atrophic cuff and no muscle behind it, because we know that if that's the case, they don't do too well either. Assuming,
I know in our part of the ARC trial, you've been very big on including a strength component, because you sort of mentioned does well, but I think if we stratify what actually is doing well, and the reason I included this guy is because he's still working.
Yeah.
potentially as a physical job. And do you want to make any comments on the strength?
Yeah, no, you've got the. I think that's a key point. He doesn't have gross weakness, but it depends if you've got to test them above head, because what really uncovers these people and these patients is what they can do overhead. Some of them are actually quite subconsciously clever at avoiding it, so they lower loads down so they don't have to do it overhead, because they've worked out, humans are very adaptive if necessary, that they can't do it. It's unreliable. So that's a feature. I think that's really important. So one of the things that has been shown in the show, we say that the better mid to long term studies is it unmasks the weakness as a real issue. Now, that's not an issue for every patient, but it is a measurable issue for many patients. So that's one of the things that we've included in our cohort in the study, is because if you ask patients, even if they've got no pain, they said, yeah, but I can't do anything above head height, or I can't lift more than a kilo. And that may be, in this setting, particularly for this guy, that may be the difference between being able to work and not being able to work. So these are the questions that we'll ask in terms of the decision making to, sort of guide the patient down a particular pathway. So you may have quite similar patients except for one or two features like this, and we may treat them differently based on their needs.
Yeah, very much. And I think that strength component in a person who's still of working age, can be
It's more an issue. Yeah.
the one thing that might push you towards something rather than not. Michael, have you got any thoughts about, ideally when would you like to see this patient, when, from a referral from primary practice? Would you rather have treatment XYZ first, or are you just happy to see them, or you want to see them straight away in case there's something else?
I'm very happy to see these early, because it can be difficult to tease out those sort of finer points without seeing. I think seeing them first means that you avoid missing the patient who's had acute cuff tear or a significant functional problem that you could potentially address early.
Yeah, and is there there's this sort of, I had a patient the other day whose kids were telling him, look, you're too old, forget about it. Do you have an age cutoff, or isn't that nice of your kids? But anyway, do you have an age cutoff?
No, I'm constantly being beaten at golf by people in their 80s, so I think I don't have an age cutoff as such. It's more their functional age that I'm interested in.
Yeah, yeah. Very good. And look, this is one of my patients, in fact, almost that exact same patient, but he could get a lot higher than 120. And, does that sort of change if they've got a really good range of motion, do you become less inclined to intervene then, Richard?
Not necessarily purely on range, but it's an underloaded range.
Yeah.
So it's very easy just to put even just like 2 fingers, and if you can overcome them with 2 fingers, and it's not just peak load, it's actually that fatigue. So can they sustain it there? And there are a lot of patients who can use trick maneuvers to sort of rip their arm up there. When I say rip, flick their arm up, and they can hold it. But you've only got to put about 5 seconds of load on it, and the whole thing just collapses. And that's, I think, tells you they're in trouble. So then you've got to look at, what the rest of the cuff looks like, for example. Is this just isolated, or have they got good other, what we call a balanced tear, a good other rotator cuff muscle and tissue that they can rehab that might compensate. But generally, by the time they've come and seen us, they've kind of been through that and they can't. And then I still have this, go back to the conversation we just had.
Yeah. I think the examination in cuff tears, can be really quite revealing.
It's not just a read an MRI report, make a decision. I think that's the key. We need to sit down with the patients and go through. It's old-fashioned medicine. I know it's maybe not as popular as it used to be. But see the patient, take a history, examine them, and then put it all together. We're still teaching medical students those core principles. But
well, speaking of anatomy, supraspinatus is by far the most common that we would see. But when we're getting these ultrasounds and MRIs, we're often seeing comments about the other tendons too, and subscap is not infrequently a bit degenerate to varying degrees, as we can see on these pictures. There's, fairly normal here, and then sort of upper split here, and then complete split there. And do you treat that any differently to the supraspinatus profile?
Yes. I think one of the keys is here is our sort of contemporary understanding of subscap is it's actually worth two rotator cuff tendons. It should be two muscles. It's the only muscle in front that controls the front half of the shoulder. And it actually has important connections to supraspinatus as well in most patients. So even an upper third or 50% tear, if it's not even completely off, will be more inclined to explain to the patient that very thing and offer them repair. Because once you get to it all off, it retracts and wastes very quickly, and it can be go from irreparable really quickly, and then the disability from that is much greater than, say, a full thickness tear isolated of supraspinatus in many patients. And then we're getting into the world of tendon transfers and a whole lot of other things, which is, a much bigger game. So, I'd be interested if Michael has got any other views on that. But that's, I think people might find we're a little bit more aggressive with even isolated subscapularis tears.
Very similar thoughts. Also, keeping in mind for me, at least for some of these, having an intact subscap will make life easier down the track for someone who needs an arthroplasty or another procedure at some point. So they tend to be pretty aggressive as well.
Yeah, I think, it's just a different size muscle, and you can see on the picture here, it's, as Prof says, it's at least twice the size of supraspinatus, so behaves a bit differently. Well, here's another common presentation, the errant dog on a long lead. Proximal humerus fractures are much more common in females than males due to porosis. But this lady's tripped over a dog. She's been to emergency. She's been given some painkillers and a sling, and sent back to primary care. Michael, would you have any comments on that presentation and what you might do?
I'd say you've very tactfully chosen that age, which could go either way based on the what this patient is like otherwise. I'd like to find out that part of her history, but the vast majority of proximal humerus fractures we end up managing non-operatively, but to come to that decision, I pretty routinely with this fracture get a CT scan to make sure the tuberosities haven't posteriorly displaced, which you can't quite appreciate on the X-ray. And then if that was the case, I'd still do serial imaging, or if it hadn't displaced, I'd still do serial imaging to make sure it doesn't over the course of a couple of weeks.
Yeah, and I agree, like the majority of these we treat non-operatively, but what is your non-operative sort of ideal treatment plan?
Based on the fracture pattern, this or this, assuming it's a pretty standard fracture, I treat them in a collaring cuff, doing just wrist finger motion for the first couple of weeks. And then I start to get them doing slightly more passive assisted range of motion from 2 weeks and move on to active assisted motion from 4, with the aim of, with fracture union, getting them to start some weight bearing and a bit more participation in physio from 6 weeks.
Yeah, it's moving them a bit earlier than the 6 weeks, which is certainly what I'm doing too. What about you, Prof?
Yeah, so the couple of studies I've seen, it's not quite on this fracture pattern you've got here, but generally it's the cut-off's around 4 weeks. So I certainly get them moving elbow and hand early, because you don't want them to have a completely swollen limb with a swollen stiff hand, which puts them at risk of CRPS or something. I think what we want to know is that this is sticky and staying sticky, and so the bits are not separating, because that GT fragment, remember, it's still got tendon attached to it, and if it is unstable, so what we're trying to do is make a guess, is this stable or unstable? initial displacement is obviously a sign that if it's not displaced, it should be stable as long as it's not loaded. Because supraspinatus will want to pull this off if it's unstable or loaded. But in this setting, there's subtle things like the calcars are intact, which mean that medial part of the shaft, it's not translated. So if this is allowed to stay sticky, sort of some motion around that, even just some gentle pendula or something, unloaded movement at around the 4-week mark seems to be safe. But I think just going back a step, and particularly if these, this would be a bit of a struggle, you'd want to be a little bit bold to manage this in primary care. Doesn't mean you can't in general practice, but you might want to phone a friend and keep in touch with a friend to monitor it. But the point is that the non-operative treatment of these kind of fractures actually takes more visits and more x-rays, because if things start to move, you want to pick it up earlier. So I sort of see them 1 week, 2 weeks, 4 weeks, and by that stage, I'm usually reasonably happy, and I might see them 4 weeks later to follow it. That is basically, I can tell you that's exactly what I did with a lady I saw today. But if things start to migrate and you get position change, it'll generally keep going. And so that we want to identify that, because it's a need to jump in early, because it's very difficult to pull a retracted tuberosity back and fix it, and therefore restore the connection of the rotator cuff.
That's yep. And your comment on more visits is, I think, telling, because the other thing I like to emphasize to the patients is this is sort of not a 6 weeks and you'll be opening the Bullen for Australia. It's really sort of 12 months and you'll probably get 3/4 function back. That stiffness is just extremely common, and persistence is really really important. But yes, as you point out, there's a high number of variations on this proximal humerus fracture. Here's the sort of AO classification of them. Letters and numbers everywhere, all different colors. So phone a friend if you need to. We're always happy to help out. And these are pretty common. And in the older age group, this lady, I think she was almost 80, and this tuberosity is completely displaced. The head's flattened, but here she is waving at me in the clinic, perfectly happy. So a discussion with the patient, is absolutely important, and outcomes don't always correlate with the X-ray findings. I've found in my experience, and I'm pretty conservative with these in that age group. So osteoarthritis of the shoulder is extremely common, but one of the difficult groups is a sort of middle-aged group, and this is a 57-year-old male who's had increasing pain for 2 years. As Prof alluded to earlier, they'd had 5 shoulder dislocations in their 20s, and they've sort of got this globally reduced range, and the X-ray, as you can see, shows a pretty arthritic shoulder developing here. And if I find this a difficult group to treat, Prof, have you got any approaches to the younger patient with the arthritic shoulder as opposed to the more retired older patient?
Well, they're harder to manage. Well, they're more of a dilemma to manage, and the reason is that historically, and still really, our concerns about the glenoid and the survivorship of a glenoid, if we're thinking about the end game, which is shoulder replacement. So we do try to wait for as long as possible. Pain is the issue, but there's a sweet spot. We know this with the shoulder, but we also know it with the hip and knee. If a patient defunctions and muscle gets muscle wasting, and the lower they start off, the less improvement they get, if that makes sense. So there's almost like when we're thinking about the end game of shoulder replacements, there's almost a fixed amount of improvement people can get. So equally, we're not going to want to treat them before they're ready or before they've got significant arthritis. There has been attempts to do what's called CAM, comprehensive arthroscopic management, which is like debridement, removing osteophytes, as a global treatment. It probably doesn't change that natural history significantly, but it does. There are some subgroups of patients who've got other pathologies, particularly like biceps pathology, for example. You can reduce their pain, and it can keep them functioning at a high level for the duration, but it doesn't defer the ultimate treatment. What to answer your initial question, what we tendency is to do sort of more, shall we say, less. When they fail non-operative treatment and they need surgery, treat the arthritis of the merits, which generally is a replacement, but to try and, where possible, select replacements that preserve bone stock. And I won't get, that becomes complicated, and there's also some availability issues currently about what is available. I won't go into that, but we try. That's why, in general practice, you might see patients have things called stemless or alternate bearing surfaces, things like that. But that really is a real case-by-case selection around that.
Yeah, it's a tricky group. Michael, do you have any thoughts after your Canadian experience on the young patient?
Yeah, yes. As you say, difficult cohort, and the reaching the treatment side of this presentation, the Canadians are a lot more inclined to put in an anatomic shoulder replacement. So there's a shoulder replacement with the ball on the humeral side and the socket on the glenoid side. They were putting in around 70% anatomics versus 30% reverse, and we're very much the opposite here. And they almost treated it as a staged procedure, knowing that it would fail at some stage, with the thought that they rely on an intact rotator cuff to function well. 57-year-old, the chances are their rotator cuff will deteriorate over not too much time from the time of the operation. But that was an interesting difference compared to what we do here.
Smart people,
Yeah.
like Canadians.
Yeah, some people as Canadians, that's right. And certainly, I think one of the key things for me is like a person in the 50s I saw the other day, like just saying, look, I just can't sleep properly, and he's just getting absolutely worn down. And I said, we'll do an anatomic stemless, on a preserved bone and trying to make the most of their cuff. But it's a real trigger, but I try and get them to hang on as long as they can. But we're also happy to treat them on their merits.
And perhaps just to give a sort of a global picture of why we're perhaps a little more hesitant than. Well, it certainly doesn't say that we won't offer somebody in this setting a shoulder replacement. We will, but we perhaps a little more conservative than our hip and knee colleagues is because we just don't have the bone stock, particularly on the scapular side, because we know that they are unlikely to get 25 years out of shoulder replacement. Although I've got patients walking around now with 20-year-old shoulder replacements that I've done early in my practice. So they, in the right patient, well done with the right materials, it certainly can survive. But when we have to do revisions, it gets complicated quickly because we just run out of real estate. We run out of bone stock. The glenoid is not a pelvis or acetabular, unfortunately. We don't have the amount of bone stock to work with to exchange components.
Excellent. Any other comments, Michael? No, I think the other, sort of perhaps something that might help, but we won't know for 20 years is, computerized planning. We're all doing that now. We're getting 3D guides to implant these things more accurately. There's navigation and robotics, so we're able to plan our complex cases in more detail, but I think the fundamentals remain the same. You don't have an operation unless you really need it.
It is an interesting point. I mean, we certainly the assumption has always been in orthopedics, in all joint surgery and replacements, the more accurately you do it, and the better the outcomes. And it is sometimes hard to show that, but we have shown it in a local study in the last 12 or 18 months that there is actually a correlation with that in the shoulder, that you can improve you certainly reduce outliers, so unexpectedly bad results, if you like, and digital planning and the measures that you said, and that's more for interest to surgeons really, but it does actually improve patient outcomes not globally, but in some areas, particularly certain movements and range of motion in reverse shoulders, which is a bit different to what we're talking about here. So in other words, there is a role and there is cost benefit. In other words, value. If we talk about value healthcare, there is value of some of this additional digital planning, because there is ultimately somebody has to pay for that. But as we do more, it's a volume. There's a volume efficiency that the cost comes down because we're doing it more. And it's probably, again, for the GPs on the call, that understanding that the fastest growing joint replacement not just in Australia, in the world, is total shoulder replacement, because the efficacy of it is been shown to be of high value. And we've got some studies that show that it's very close in terms of not cost benefit value, but also in terms of patient perceived value. It's very close to total hip. It actually sits above total knee in terms of return for patients. So it's worth considering it as an option in the appropriate patients, definitely. So it's a plug for shoulder replacements with my bias.
Yeah. I mean, yeah, and I think the other point is we really don't have another effective treatment for arthritis of the shoulder. We're unaware of any really reliable way of slowing or changing the natural history as yet. There's certainly plenty of work in that space, but
there's no pill, potion, rejection, or stem cell that cuts the mustard, really.
And we love one.
So we're not going to be out of a job for a little while.
Yeah. Oh, peptides. I get asked about peptides a lot. Thanks, everyone. Another plug for Health Pathways. I think we've covered off the majority of cases. There's certainly some questions I can see appearing in the chat that Richard has been excellent in commenting on. Our website and phone number are there if you ever want help looking at the 14 different proximal humerus classifications, or a mammal has fallen off his bicycle. I'd just like to say thank you, and thank you to Prof, and really welcome to Michael. He's just been an absolutely fabulous addition, and we're very excited to have him.
Very much. Echo that. And Helene, thanks for organising. Kevin, thanks for putting the cases together. They were great, and really enjoyed just the questions that came in from those online.
Thank you, and thank you for taking the opportunity and the time. I know how busy you are to speak to our members, and your details are all in the chat, I think. So if there's any other questions, I can pass them on to you as well. So I will just end this webinar now, and thank you all for attending.
No problem. Good night. Cheers all. Thanks all.